Well, hello, this is Dr. Philip May. I'm going to be speaking to you about osteoporosis, a common problem in persons with medically complex disability, including those with developmental disabilities. First off, the microscopic pathology of osteoporotic bone is shown on the right side there, reveals a tremendous loss of trabecular structure. The cortex is not shown in this slide, but you can see there's an awful loss of trabeculi, which weakens the bone, so the bone loses a lot of strength. In addition, there can be fractures in the spine, crush fractures or wedge fractures, as shown on the right-hand side, and also in the hip. There can be fractures of the neck. There can be intertrochanteric fractures, and there can be fractures of the shaft of the femur as well, proximal shaft. There can be loss of height. Kyphosis can develop. How is osteoporosis diagnosed? Well, we're going to be talking about that, but one of the components of the diagnosis, but not all, is the DXA scan. Shown here, this is a GE lunar scan. The person lies still under the scanner and in the proper position with the feet strapped to the device there, and so that there's a little inward pointing of the toes, and the scan goes across the spine and the hips, and a report is generated as shown here. This is the DXA report, and listed on this is the World Health Organization criteria for osteoporosis. Okay, and here it is, the World Health Organization criteria for osteopenia and osteoporosis. A normal DXA scan is defined as a T-score of greater or equal to minus 1.0 standard deviations from the mean. And this is a comparison with a young adult white female population, so whether they're men or women, although we do have normals that are age and gender matched. The Z-scores sometimes are used for younger people. But in general, this is what people usually go by, is the T-score. So you can see that if you have a T-score of minus 1, that's still normal. But anything less than minus 1, like minus 1.1, you get into the osteopenia range. So you can see osteopenia is defined as a T-score of minus 1.1 up to minus 2.5. Minus 2.5 or lower is defined as osteoporosis. And if there is osteoporosis with a history of fracture, that is, the T-score is less than or equal to minus 2.5, below the standard deviation, that would be classified as a severe fracture. Now this slide, you can see it doesn't have the minus sign in front of the 2.5. There should be a minus sign for osteoporosis and severe osteoporosis. But I want to point out that that's not the whole story. The bone mineral density is defined by DXA, is very important, but as we'll be talking in subsequent slides, it's not the whole definition. Now this is the definition of osteoporosis that I think most experts use today. It is the NIH Consensus Conference definition. And in that conference, there was a new definition of osteoporosis created. Before that, it went strictly by the bone mineral density. But after the consensus conference, osteoporosis was a bit redefined. And osteoporosis is defined as a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk for fracture. That's the definition. So it's loss of bone strength. Bone strength is a concept. There's no direct measure of bone strength, but bone strength reflects the integration of two main features, and that's the bone density, as determined by DXA, and bone quality. Bone density is expressed as grams of mineral per area or volume, like grams per centimeter squared, and in any given individual is determined by peak bone mass and amount of bone loss. Bone quality refers to architecture, turnover, damage accumulation, for example, microfractures, and mineralization. So when you're assessing someone for osteoporosis, you have to think about the DXA, what the DXA report is, which is about 70% of the strength, but also there's the issue of bone quality. So you can have a normal bone density, but if your bone quality is diminished and that reduces your bone strength, you can technically have osteoporosis. Bone turnover markers come into play here. So if you had a low bone mineral density, your risk for fracture increases, but if your bone turnover is also increased, your risk is even greater. Now you can see the third diagnosis down as osteoporosis. Just as a comparison of the frequency of osteoporosis with other conditions. For example, high blood pressure is a very common disorder. 30 to 50 million have that. Hyperlipidemia is another real common medical condition. 50 million people. Osteoporosis is right up there. It's pretty common. 26 million people. It's more common than diabetes. Developmental disabilities is put in here. 3 million people. Not that many total. But the question is, how many of the 3 million have osteoporosis? And I would guess that quite a large number. The estimate in the adult population is probably 50 to 80% have some loss of bone mineral density, which puts them at risk for fracture. But this is a much more common problem than HIV, and of course there's a lot of focus on AIDS and HIV, but not so much on developmental disabilities, and that's what we're trying to improve here, the physician awareness about the problem of developmental disabilities and how bone health is a major issue in this special population. The lifetime risk for fracture in the general population for women is 40%, in men is 13%. In my experience, the risk for fracture of people with developmental disabilities resembles more the female incidence of 40%. I think in most practitioners' experience, if they looked at their caseload, their patient population, people with developmental disabilities, that about 40 or maybe 50% would have a history of fracture. So fractures are very common in people with developmental disabilities. The annual cost of osteoporotic fractures in the general population is $13 to $15 billion, so a lot of money. Risk factors for osteoporosis. In general, they can be divided into non-modifiable or modifiable, something you can do something about. And the non-modifiable factors include age, just genetics, female gender, the white race. Things that you can change are exercise, diet low in calcium, not getting enough sunshine and vitamin D, smoking, alcohol abuse, and excessive caffeine can be associated with osteoporosis, and things that you can work on. But the caffeine issue is not completely clear, but certainly the smoking and the alcohol are risk factors. Now, looking at the FRAX risk factors, this is another way of looking at risk. The fracture risk assessment tool, which you can access online. It's a pretty neat little feature here that you go on this website and you enter a few numbers and pop out comes the 10-year probability of fracture. And the risk factors that FRAX looks at are the age, gender, weight, height, gives you a body mass index, history of previous fracture, a parent with a hip fracture, currently smoking, taking glucocorticoids, rheumatoid arthritis, secondary osteoporosis, which I'm going to show on the next slide, some examples of secondary causes, and alcohol, 3 or more drinks per day, and the bone mineral density are all included in the FRAX risk assessment tool. Bone turnover is not included in the fracture risk assessment tool at the current time, but there is a lot of evidence that bone turnover is a separate risk factor for fracture. Now, these are clinical disorders associated with osteoporosis, which can lead to what's called secondary osteoporosis, neuromuscular disorders, drug side effects, especially anticonvulsants, neuroleptics, steroids, proton pump inhibitors, hypogonadism, genetic syndromes, low intake of calcium and vitamin D, hyperparathyroidism, hyperthyroidism, Cushing's syndrome, pituitary failure, intestinal malabsorption like celiac disease, which is probably more common than we think in people with developmental disabilities, renal failure, liver failure, rheumatoid arthritis, and diabetes mellitus type 1 would all be considered as a secondary contributory factors to osteoporosis, or at least affecting bone mineral density. When to consider a pharmaceutical, a drug treatment in postmenopausal women and men older than 50 can be based on the following when you're using FRAX. If there's a history of hip or vertebral fracture, consider a pharmaceutical. Just that in itself is enough. If the T-score is less than or equal to minus 2.5 of the femoral neck or spine, after you've ruled out secondary causes that can be treated, consider a drug pharmaceutical. If the T-score is in the osteopenia range, that is, it's minus 1.1 to minus 2.5, with a FRAX test result of greater than or equal to 3% probability of a hip fracture and a greater than or equal to 20% probability of any major osteoporosis related fracture at 10 years, then consider a pharmaceutical. But lastly, regardless of 1, 2, and 3, clinical judgment and patient preference always should be considered and may suggest that a drug be used, even though they may not meet these criteria of 1, 2, and 3. Now, the National Osteoporosis Foundation indications for anti-resorptive therapy, this are like bisphosphonates. They suggest anyone with a T-score of less than minus 2.0 or patients with T-scores between minus 1.5 to minus 2.5 if there's a family history of osteoporosis, a previous fracture, current tobacco use, or a body weight less than 127 pounds. Types of osteoporosis encountered in adults with disabilities, including developmental disabilities. There are 7 different types of osteoporosis that you may encounter in someone with a developmental disability. First, developmental osteoporosis, known as the low peak bone mineral density syndrome. The peak bone mineral density increases to maximum and begins to level off at about age 25, and then it's stable from like 25 to 45 and then starts to decrease. If kids don't get a lot of exercise or they have vitamin D deficiency in childhood, they may not attain a very good peak bone mineral density, and this will be read as a low bone mineral density, either osteopenia or osteoporosis. This may not be an active process. Bone turnover markers may give you additional information about that, but consider that if the bone mineral density is low, they may not be actively losing bone at that point, but they do have a low bone mineral density. Secondly, vitamin D and calcium deficient osteoporosis or osteomalacia, which is associated with increased bone turnover as well as a low bone mineral density. Aging-related osteoporosis, and this, if it's a pure aging-related or senile osteoporosis, usually the bone formation is reduced more than the bone resorption. So you may see a reduction of bone alkaline phosphatase or P1NP out of proportion to the CTX, for example. If it's postmenopausal osteoporosis, it's the loss of the estrogen inhibitory effect on the osteoclast. You'll see the CTX rise, and if there's an element of aging, the P1NP or the bone alkaline phosphatase will not go up that much. So the bone resorption is out of proportion to the bone formation. And the same occurs in men. With disuse osteoporosis, which is related to inadequate weight-bearing physical activity, you can see both a reduction of bone formation and an increase in bone resorption. So you may see a lowish P1NP and an elevated CTX. Drug-induced osteoporosis is something that is a very complex condition, and it can be related to vitamin D deficiency or a direct effect of the drugs on bone. So in the future, I'll have a talk just on this slide. We'll go over the different types of osteoporosis that the practitioner needs to consider in selecting treatment for someone with a developmental disability. It's usually a more complex process than simply postmenopausal osteoporosis. Additional risk factors for adults with developmental disabilities include the polypharmacy, vitamin D and calcium deficiency bone disease, seizures, impulsive behaviors, and motor dysfunction are all commonly observed in people with developmental disabilities and can contribute to a risk for fracture, risk to loss of bone mineral density. Treatment of osteoporosis in general includes dietary, exercise, and pharmaceuticals. Weight-bearing exercise is very important. You can see these ladies balancing weight on their head. It doesn't necessarily mean you have to walk around with a bunch of fruit on your head, but bearing weight walking, running is all very important, and actually will inhibit the osteocyte from causing loss of bone mass. Now, just briefly, a couple of case histories. These are both men. When you talk about osteoporosis, most people think of this is a woman's disease, but men can get it too. And the first one is a 35-year-old man with a history of a hip fracture. And as it turned out, he had severe osteoporosis. On the left-hand side, it shows the preoperative fracture and then the pinning that occurred. When he eventually got a DXA scan a number of years after this was done, severe osteoporosis was noted of the right hip, and he was placed on anabolic agents to try to build the bone mineral density. And in a 45-year-old male with the fracture of the left clavicle, he had osteopenia, and again, it was confusing to the practitioner, primary care practitioner, whether this should be treated with anything because he was a male, and men don't get osteoporosis. So this is to point out that if the fracture occurs in men, they should be worked up, and if they have a loss of bone mineral density, then treatment should be considered. So in conclusion, osteoporosis is common in people with developmental disabilities. There appear to be multiple mechanisms. There's a need for more research to document frequency and effective treatments. The efficacy of treatment should always be documented with bone mineral density, and in my opinion, bone turnover markers should be obtained. And of course, whatever your treatment is, make sure there's plenty of calcium and vitamin D to make sure that the basic elements are there for bone to become healthier. Okay, thank you very much for listening. That concludes the talk. If you need to get in touch with me, send me an email to ifcd.pma@gmail.com, or you can visit the website where there are other lectures that are related to bone health on YouTube. So I hope to hear from you, and thanks again for listening. Bye-bye.